Welcome to the Urology Coding and Reimbursement Podcast, where we help urologists and staff achieve peak economic and practice efficiency so there is time and energy to focus on patient care and a happy life. I'm your host, Scott Painter, with my co-hosts, Mark Painter and Dr. Ray Painter. Welcome to episode 55 of the Urology Coding and Reimbursement Podcast. I'm your host, Scott Painter, with my co-hosts, Mark Painter and Dr. Ray Painter. And today we want to welcome again Dr. John Lynn. Welcome. He's a solo practitioner in Gilbert, Arizona, which is in the Phoenix area. I'd say the Phoenix area. And he runs the Thriving Urology Facebook group. So please, if you're not a member already, it's great to join. So we encourage you to join that Facebook group. We wanted, John brought this topic to us again because we're seeing a lot of questions on medical decision-making out there on the E&M 2021 rules. So we wanted to go over that and have a discussion. And John, first of all, welcome. And you had a question on the Thriving Urology Facebook group. And we wanted to start there and see if we can't clarify a little bit on medical decision-making.
Yes, you bet. Thank you so much for having me again. It is always so much fun. This question came from Michael, and he's wondering about medical decision-making when it comes to E&M services relative to scrotal pain. So his question starts like this. I'm still having a hard time with less straightforward medical decision-making. This was a referral from my primary care docs in our multi-specialty practice. I had a patient with left scrotal pain for 3 months. He fell from a ladder and had back pain that radiated down to his leg and likely his scrotum or testis. His urologic examination is unremarkable. Urinalysis is normal. I ordered a MRI of the lumbar spine. The best I seem to get is a level 3 E&M, but it seems to be more complex. Thoughts and justifications. Mark, what do you think?
That's a tough one, and it is one of those that kind of falls into that area. The system is designed, and I think better designed than we have in the past, to try and accommodate the thought processes that physicians go through to treat diseases. But as with anything, it's a shotgun, so it's going to miss some things. But if you look at what the problem is, you've running it through the medical decision-making wheel. We've got to say, is this an undiagnosed new problem, or is this from the problem of that the urologist is going to manage? Is it an acute, uncomplicated problem? So, those are the two categories I would put this in. I don't think most people would think that this is a problem that's typically going to last more than a year or until the death of the patient at this point in time with an unremarkable testicular exam. Now, the MRI, maybe you suspect some nerve damage or something with the back with this particular piece, which that wouldn't necessarily be a problem that the urologist is going to manage. But at this point in time, in the presenting problem category, because he hasn't fully diagnosed it, I think there is a possibility to call it an undiagnosed new problem. And that's kind of where I would land. A lot of times we look at testicular pain as an acute, uncomplicated problem, like an epididymitis or something like that, something that we can, tackle fairly quickly, or a trauma that's gonna to the testicle itself that's gonna, potentially resolve on its own, which would maybe make it self-limiting or minor. So, in the end, testicular pain isn't I mean, it could be from cancer. So, that testicular pain could run the gamut of a lot of different things. But again, he's saying it's unremarkable on exam, but he is ordering an MRI. So he doesn't know for sure what's going on. So at this point, I would still count the presenting problem as an undiagnosed new problem. So that would give us a level 4 in that presenting problem side. It sounds like all he's done in this visit is order one test, an MRI. It didn't say that he looked at a UA or did anything more than a physical exam. Is that, am I getting that right, John?
I think, let's see, UA is normal. So just an MRI and a UA. So 2 in the data.
So 2 in the data. Okay, so we got two in the data, which would get him to a level 3. So we know we're at least a level 3 with the data. And then the risk on this one, the risk from the lab test that's ordered, the MRI, is low. It doesn't seem like there is anything else in his note that would indicate that he thinks that this really needs high active intervention and, kind of would elevate that to a moderate category. So I have to agree with him where he's coming down is that this is a level 3 that maybe seems like a little bit more complex of a problem. And so kudos to him for actually understanding the guidelines and ultimately, yeah, there are going to be places where your work is not really commensurate with the level of thought process that you're coming through. And, the hope is overall that you'll level out that, some of your patients, like your 2 stable chronic diseases with drug management, with your ED, BPH guys who are stable and you're just keeping them on tamsulosin or Cialis or Viagra, any of those things that are fairly quick visits are going to hit the 4s. That really aren't as complex as this particular case. So in the long run, it probably levels out, but you're definitely going to have individual cases that don't fit everything you run through in your head.
Yeah, this one doesn't seem quite fair given the amount of mental work that he has to go through. If you're just looking at the ENM levels, going through the problem, data, and risk, you can only get up to a level 3. But the thought process behind it seems to be a little bit more. And I agree, Michael did a great job in thinking this through and laying out the data and the thinking process. But yes, he thought it should be more complex, but unfortunately, it's only a level 3. But what about Ray? Let me ask you, what are your thoughts?
Well, I think you're right. Unfortunately, under the old system, we could add up diagnosis, and obviously he's thinking of a ruptured disc. And from the clinical symptoms, etc., that's probably what it is. And from somebody that has chronic back pain, a few ruptured discs, I can tell you that's a chronic problem, but it still doesn't get you any higher. And the risk of management is just exactly what you say. If he had ordered a pain pill, he would have gotten to a level 4. But under the rules, I would stick with a level 3.
Yeah. So Mark mentioned so first of all, let's just make sure that everyone's on the same page. This is E&M from an office visit. So this is an office or other outpatient. So we are talking about medical decision-making instead of billing based on time. And in this case, it's a level 3, despite the mental work that Michael had to do. What about, let me ask you this, and this, I saw 2 of these cases, some young guys coming in with non-specific scrotal pain. There's no history of trauma, no signs of sexually transmitted infection, no new partners, and he just has this intermittent achy scrotal pain. And I examined the patient. Everything is normal. Out of overabundance of caution, I order an ultrasound, and the patient's agreeable to take diclofenac, Voltaren, which is a prescription drug medication. And what do you think about that, Mark?
So, I would have to say, given your description, you're going to still classify this as an undiagnosed new problem that first time through. You're not really sure what's going on, and that's why you're ordering the ultrasound. And I would encourage you to, in your order of your ultrasound, put something in to rule out something, just to clearly say that, that diagnostic ultrasound is being done, not just precaution, but potentially to find something else to rule out. So you indicate to a coder or an auditor that you really are doing something diagnostic to close the loop there. And the prescription drug is prescription drug management. So with those two, even though your data is not going to get above a level 3, because I'm assuming you probably did a UA on the guy, that ultimately that's a 4. You've got an undiagnosed new problem with the prescription drug management, and so that one fits into that category of level 4. But again, encourage you to add that documentation to your ultrasound order. A, to be clear on why you're ordering the ultrasound, but B, to make sure that the coder understands it's an undiagnosed new problem.
Yeah, typically I try to remember to write in my assessment plan that this is an undiagnosed new problem requiring additional workup. Yeah,
that's a good way to do it too. And the other thing is, remember now that the new guidelines do say that it's an undiagnosed new problem with potential risk. So not just additional workup, but that that it could be something like testicular cancer, or something that is a high risk of morbidity or mortality to the patient. So that's why I would go that one step further with that additional verbiage in the guidelines this year.
That's a great point, to make it absolutely clear to any potential auditors or your coder. The definition of undiagnosed new problem is a problem in the differential diagnosis that represents a condition likely to result in a high risk of morbidity without treatment. So to make it very simple for the coders and billers who may be abstracting from your note, or any auditor, it will probably make it super simple if you just wrote that down. Hey, I'm worried about possibility of testicular cancer that I could not feel, could not palpate on examination. Scrotal ultrasound will be ordered. So that's a great suggestion.
Yeah, I think we're going to be we're in the learning curve stage, right? For all of us, including the auditors, because it's new to everybody. We're all starting with the blank slate. But yep, that extra mile, and quite frankly, I'm sure from a medical legal standpoint, that rule out is something that you would want to add in there anyway, because that has to be in the back of your mind, at least to some degree.
Ray, what do you say?
I think you're on the right track. You have to differentiate in your diagnosis between the acute complicated or undiagnosed and an acute uncomplicated illness. So the acute uncomplicated is something that is going to clear up with a little treatment. And you want to differentiate between the two.
So it's interesting to contrast these two scenarios. One is a scrotal pain or testicular pain that may have been a neurologic injury. You order an MRI. And the second is just a run-of-the-mill scrotal pain that you don't know what caused it, and you're ordering an ultrasound. You got a UA, and you prescribe the diclofenac. The difference in the E&M level. So it's interesting how things change based on just very small 2 millimeter shifts in what is actually done. And understanding the rules of the game, make sure that you're not leaving money on the table when you're already doing the work.
Yeah, and I'll also add on all this stuff that's always interesting to me is sometimes the reimbursement pressure, if you will, the business pressure on physicians. And then you throw in from the other side, all the other pressures that physicians deal with, like, not over prescribing narcotics or, pain meds and those types of things where, the first case you're talking about, Ray mentioned, if he just would have given him a pain pill, it would have bumped it to a level 4, when in fact, you're also on the other side with everything going with the narcotic side to try and steer clear of some of those things. So it's, in the end, I think looking at it as it's going to average out, and continuing to practice good medicine and putting your thought processes on paper is important, because I can tell you now that COVID is, starting to be navigated around, let's say, not going away, but we're getting to the point where we're figuring out how to live with it. At least it looks like that right now. That the insurance companies are moving back to the value-based push, and we are seeing their contracts are starting to look at how well you treat your patients. Are you following clinical guidelines? Are you taking a look at the population-based health initiatives that are out there? And that pressure is going to increase as well. So sticking within guidelines, following those types of things, and noting that you're doing that is going to become more important within your compliance program, and the consistency within each medical record is going to be important as well.
Yeah, documenting the thought process is going to be important. And gosh, I wish there's a way to encourage physicians to write down or to articulate in the electronic records, typically for most of us now, the thought process. And if we all did that, it would make auditing a lot easier. It would make defending your E&M levels a lot easier.
Yeah, I agree.
We've seen.
Go ahead, Scott.
I was just going to say, along these lines of looking at the questions that we have coming in with regarding the E&M 2021 and medical decision making, a lot of them are coders asking a question saying, my physician feels like this should be a higher level. And we've had a number of those questions. And so, it kind of goes back to what you were saying, John and Mark, that this indeed is, you got to take your feelings out of it and really look at what is being, according to the rules, what's being done, what's being, what's being presented, what the problem is, what the data is, and the risk.
Like I love saying, CPT rules and Medicare rules do not care about your feelings.
So true.
Well,
they often don't care about reality.
And physicians could make it so much easier on themselves if they just spend a little time to understand the basic concepts by which the rules are based.
One of the things I found very interesting as I've been looking at the various approaches to medical decision making before and now, especially after the guideline changes, the number of different thought processes on how to get medical decision making on paper. I think I'm seeing a lot of physicians who are expanding their dictation a little bit, their voice recognition in their EHR, or their typing in their overall risk management piece. But I actually have also run into a couple of different groups who have started building thought process check templates that they're more comfortable clicking through things, and they've got some forms that they've put in electronically that have some of those decisions that are common within this, the rule outs and those types of things that they can check through to help them stay on target, if you will. And it's interesting to me as you look through all of this and you think about the guidelines and you think about what's going forward, that in some ways that check process that kind of gets everybody on the same page for the majority of things that are out there makes a lot of sense, but at the same time takes out a lot of the I don't know, the art of medicine that really is, I think, the way a lot of physicians individually go and approach medicine and healthcare. So I think it's going to be interesting to watch how far the guidelines drive us into a little bit more of a regimented thought process, a regimented routine, and how that is going to be translated into use of the electronic medical record.
I wonder where they're documenting that. I assume some sort of guideline-based checklist. I guess maybe in the HPI.
So actually, they're doing it in a couple of different spots, and one is in the HPI, and the other one is in the orders for their tests or their surgeries, and some of them are actually setting up. I would say, templates for like procedures and what the findings are relative to that. So there's a number of different places where they put those things in, and people have gotten very creative in that overall process.
Oh, I get it. In the assessment and plan, under the diagnosis, you create a protocol, and under the protocol, you have the pre-op discussion, which will include the verbiage to drive a certain E&M level or medical decision-making level, having the appropriate language to use to make sure that all the checks are marked.
Right.
Makes sense.
Yeah. So it is. I mean, people are getting creative, and they need to.
Documentation is the bane of my existence. I can tell you that. I'd rather just see patients face to face and then just make the orders and be done with it instead of writing a story, which unfortunately is the same thing over and over. Thankfully, voice recognition is going to save my butt.
Yes.
No doubt.
And I think a lot of people are going that way. And to me, that makes a lot of sense. And so, you've got to go with what makes sense to you and ultimately what you can use as a tool. And voice recognition software has gotten so good. If you speak in longer sentences and you train your systems, it's just getting better and better all the time. So I certainly understand why that's going to be, I think, the predominant method of going through things.
Yeah, you buy the software once, or I think Dragon 1 is now cloud-based, so you can take that with you literally anywhere. I mostly do my work in the office, so I just have it loaded up on these computers. And I can speak so much faster, and it just really offloads the burden of having to type. I can type pretty fast, but over the years, it's just gotten old. And when I can just speak my mind and it gets recorded in the EHR, it's just so much simpler. I don't have physical fatigue, fingers fatigue. Mental fatigue is much less because I'm just dumping my brain into the chart as soon as I see the patient. In addition, these the voice recognition software systems have the ability to create macros or auto replace text or dot phrases in the EHR realm. So you can, for instance, I can say SIG consent. It'll automatically write the verbiage of the consent in the chart, or SIG findings. It'll say findings, implications, treatment options were discussed with the patient. So you don't have to say the same thing over and over. In long form, you can use shortcuts. Or for instance, I can say SIG established for telemed, and it's automatically going to pull up. It'll try to close the chart. It's going to bring up the billing portion of the EHR, click on level 4, and click on the modifier needed for E&M for that particular payer, and just waits for me to make sure that everything's perfect before I hit OK.
Yeah, and I mean, wow. Using that, you could really translate those forms into voice recognition, and I mean, which is essentially what you're doing in those processes. So there, in the end, it may be a blend that gets you in place. And now you got to you're just stuck remembering how you, how you shortcut everything. And it does go back, I think, to what Ray was saying, in that, in the end, if you as a physician don't understand the rules and the end game, because with voice recognition and actually doing more dictation, you're now relying on your knowledge of the coding system, as well as your knowledge of what the patient's going forward, and being thorough in communicating your thought process to drive the codes.
So Mark, in regards to medical decision making and E&M levels, somebody has mentioned in the Thriving Urology Practice Facebook group about E&M calculators. What are your thoughts about E&M calculators in light of 2021 E&M coding changes?
So I'm definitely watching E&M calculators and the EHR companies tweaking and trying to catch up with the changes. And the efforts are there to get those things better, but they are still limited by their approach. And a number of those EHRs are template driven, click driven. So as you start using the voice recognition to do your assessment and plan, you're essentially going off the reservation, and you're sidestepping the ability of the EHR and the EHR calculator. So I guess in the end, I would say you've got to understand your calculator as to how you can trust it. So number one would be understand how it works. And if it doesn't actually follow the way you practice, you're going to have to sidestep it. And then the second thing is, if, in the end, you don't know exactly what the rules are, because those EHRs aren't yet programmed to meet the nuances of the new guidelines, because they're still changing. So it's important now to understand what's going on, and to question your EHR calculator, or in fact, if you're not using the templates and it's template driven, you're going to have to sidestep it altogether. And so it really is dependent. I'm not going to say they're all bad or they're all wrong. But they are very much limited, because it's a tool. And if you don't follow the steps that the tool requires, it's not going to give you an accurate answer.
Well, pre-2021, I pretty much had click fatigue. It was crazy how you have to satisfy all the points in HPI, reviewer systems, physical examination for a new patient. And I'm so happy that 2021 E&M rules made it a lot easier, concentrates everything on medical decision-making. And for the EHRs that still require a lot of clicks, I guess they're just capturing the clicks for data, the data section. And I wonder, in light of the new technical corrections by the AMA recently, how are they distinguishing? Are they distinguishing between the CPTs that have it's a professional component, no professional component attached to it, such as a CBC, urinalysis, PVR. So these are all CPTs that don't have an interpretive component to it, and you can bill for it, even if your practice is actually billing for the codes. How are they picking that up, right? If you order and review, but if your practice or entity is billing for it and reporting on it, how is the EHR distinguishing that, or taking that out, or including that in the calculation? That's one thing. And the other thing is, as we all know, too self-limited or minor problem makes it a level 3 problem, and too stable chronic illnesses makes it a level 4 problem. How is the EHR picking that up without the physician actually clicking on each problem, saying that, okay, this is a stable chronic illness? And does the physician understand what is a stable chronic illness? Does the physician understand what is a self-limited or minor problem? So those are all my questions when it comes to these EHR calculators.
Yeah, And as they've gone through, there's some of those you can answer with the computer, and that's kind of what you have to think about. In that, ultimately, if a code does not have a 26 modifier or a work value, then it's going to fit into that category of non-interpretive. So that leaves, the majority of your pathology section, which has no work value, and most of them don't have a 26 modifier. And then your PVR, which falls into that category. So there is a way to classify most of that, so the computer could make that distinction. But you're right. In the end, if you're not clicking on those orders or clicking on the two stable chronic illnesses, the computer is going to have a hard time recognizing those from a pick list, if you will, because BPH with LUTS could be stable or not. Like you can't drive that on the diagnosis side. So there has to be some additional clicking or some additional AI that would apply to that. And somewhere we'll get to the AI that will do that. But we're not there yet.
Well, Mark, with that question in mind and that discussion, if I'm the average urologist out in private practice and I have an EMR that is a good EMR, but it may not be totally brand new, am I to assume that I probably shouldn't trust the E&M calculator?
Yeah,
take a look?
I would say most urologists that I work with don't use the templates well enough, or follow the thought process of the templates that are given to them in their EHRs to trust them, for sure. And again, as I mentioned, most of them are making changes to try and get there, but they're not there yet. It could give you some guidance, it could give you a look, but it's not the be all end all. And ultimately, all of those EHR companies are going to tell you that those are recommendations. They are not responsible for those. In the end, you are. So the physician is. So you definitely need to know and choose on your own.
That's a big impetus for me to learn this minutia and these rules. Is that I don't look good in orange. I don't want to go to prison for doing the wrong thing when it comes to coding and billing.
That and nobody likes writing a big check for a take back. Those are those are painful as well.
Very important.
On the other side of the coin, you don't want to leave a lot of money on the table, so you should, and it's not that complicated. I was really happy to see the new guidelines come in because it went back and allowed physicians to practice like I did. Back in the old days, you did a medically necessary history and physical, and your main dictation was aimed at medical decision making. And as John says, with the new voice recognition, it just seems so easy to get a rudimentary knowledge of the system where you understand it and do your voice recognition, and it really makes things easy.
And for those who are not using voice recognition, I'll give you an example of how easy it is. For instance, a patient comes. This is exactly, literally, what I say to my voice recognition system, and it automatically types it out, and I can speak it at this cadence. For instance, patient presented on 6/10/2021 with AUA symptom score 6, bother score 2, and PVR of 63 cc's. Period. I mean, you can't type that fast.
No.
When I say 6/10/2021, it types 6/10/2021. So I'm speaking in fairly natural language, plus you have to put in the punctuations, but it automatically recognizes things such as dates. Or when I say clinical T1C, it automatically writes the number 1, Arabic number 1, and then lowercase c. Prostate, adenocarcinoma of the prostate. It recognizes words such as patient was made aware that bladder cancer is a polychronotropic disease, and it automatically types in polychronotropic for me.
There's a common theme here. If you listen to it, you got to put some upfront work into it, both in the medical, learning the new guidelines and getting really proficient at that, as well as there's some tools out there that you got to, with voice recognition, you got to learn how to use it efficiently. And once you do those things, put that upfront work in, it will save you time and money and in the long run.
Yeah, a couple of resources. Obviously, the Thriving Urology Practice Facebook group is free. And when I hear free, I'll say I'll take 3. So it's free, and you can ask questions on the platform, on the Thriving Urology Practice Facebook group. We talk about these types of things and how to run your practice more efficiently, EHR calculators and billing and coding and voice recognition and virtual assistants, in real life assistants, how to utilize your PAs, APPs, etc. I'll give another resource for those who are billing for actually the performance of PVR, performance of CBC, what else is testosterone. If you're billing for those services and you're wondering, wait, can I count that in my lab, in my data section as a lab or not? Basically, how to look up whether a particular CPT has a PCTC indicator. I created a YouTube video, and if you look up which CPTs are results only, which means you can't count that in your data section. Which CPTs are results only? You'll probably find that video where I talk about how to look up the PCTC indicator when it comes to E&M coding and the technical component.
Very good. Thanks, John, for all that, those resources. And I think it's a good stopping point for this episode, and a lot of great information today. Let's go around the horn. Ray, final thoughts.
Well, learn the basics and dictate what you're thinking, but you need to learn how you need to think in documenting.
All right, Mark?
Yeah, I think we've gone around to talk a little bit about tools and approach, as well as the thought processes that are there, and investing in both to optimize your day is going to be key as you go through this stuff. So know yourself and put in the time would be my recommendation.
All right. And John?
As always, I'd like to say that your patient's success depends on your success, depends on your practice's success. And these rules, these E&M things that we're talking about are just means to make sure that you are not leaving money on the table and that you are successful. And to that end, PRS Network has seminars to help you get there. So back to you, Scott.
Yes. We'd love to have you join us for our Urology Advanced Coding and Reimbursement seminar. We have one coming up in Las Vegas in December and one in New Orleans in January. And you can find all that information. We'll put it in the show notes. If you go to prsnetwork.com/055 for episode 55. And we'll also put links to how to join the Thriving Urology Practice Facebook group, as well as the other pertinent information we discussed in this episode. So thank you all for listening. Ray, take us out.
Happy coding.
Thank you for listening to the Urology Coding and Reimbursement podcast, where we help urologists and their staff maximize income and efficiencies so there's time and energy for patient care and a happy life. Special thanks to Carl Painter for the music today. You can find his music on Spotify under his record label, The Juicery.